Welcome to Lesson 2. Here we will focus on a review of the treatment of pediatric bipolar disorder. And the verse guiding this lesson is from Psalm chapter 9, verse 9 and 10. The Lord is a refuge for the oppressed, a stronghold in times of trouble. Bipolar disorder can occur during childhood in a number of different ways. And let's just take a look at the different types of bipolar disorder. Bipolar 1 will have cyclic changes between mania and major depressive episodes. Bipolar 2 has episodes of major depression, but only hypomania. And cyclothymia is the disorder where there are episodes of hypomania and some depression, but not meeting criteria for a major depression. And then unspecified bipolar disorder is subthreshold episodes of mania or hypermania with or without depression. Mania is defined as abnormally and persistently elevated, expansive, or irritable mood, as well as abnormally or persistently increased goal-directed activity. So it can look like a very focused, active individual doing many things, or it can look like somebody very silly. And another presentation of mania can be very irritable. So there are different types of presentation of these behaviors. They are increased, enhanced, and they have to last for at least 1 week. And most of the day, nearly every day, and need to include 3 or more of the following, and 4 if irritability is the chief complaint. So inflated self-esteem or grandiosity, a decreased need for sleep, being more talkative than usual, having a flight of ideas or just going from one topic to another, or racing thoughts, or highly distractible. And as well, an increase in goal-directed activity, taking on lots of projects, joining lots of clubs and groups and sports, and or the increased activity could also look like psychomotor agitation, restlessness, shaking of arms or legs, pacing, things like that. And as well, increased impulsiveness or getting involved in activities that have negative or painful consequences. Now, they may need to have some type of impairment from these behaviors. These behaviors are interfering with their life in some way. And as well, mania, if untreated, can progress and actually cause marked impairment. Hospitalization might be needed, and it can progress to psychosis. And again, hypomania is a subthreshold type of mania where there may be just some abnormally or persistently elevated, expansive, or irritable mood and increased goal-directed activity. And it is at least 4 days and most of the day, nearly every day. And it must contain 3 or more of the above, 4 if irritable. And again, those are similar: inflated self-esteem, a decreased need for sleep, being more talkative than usual, flight of ideas or racing thoughts, increasing goal-directed activity and psychomotor agitation, and again, those impulsive activities with painful consequences. Now, there does need to be a change in functioning, level of functioning, that is observable by others. Now, a difference here with hypomania is often there's no marked impairment. So it's not as severe, it's not impairing. Yes, it's a change in functioning, it can be observed, but it's not yet impairing or causing such trouble. It doesn't require hospitalization, and psychosis does not develop. And again, this hypomania is not related to another cause, such as a substance use. The prevalence of bipolar 1 as well as bipolar spectrum disorders in adults is estimated to be between 1 and 5%. And the majority have their onset with symptoms before the age of 20. So it's important for child and adolescent mental health providers to be aware. In clinical populations, the prevalence of bipolar disorder in youth in the United States has been reported to be between 0.6% and 15%. And that depends on the setting, the referral source, and the methodology to diagnose bipolar disorder. So we see that that is a great difference between 0.6 and 15%. And there has been a focus on trying to decrease overdiagnosis of bipolar disorder in children because many children present with symptoms that appear very much like bipolar disorder. And so when the DSM 5 was released, we have the new disorder, dysthymic mood dysregulation disorder. And that disorder, the goal of that was to prevent overdiagnosis of bipolar disorder. A more recent meta analysis of the epidemiology of bipolar in youth enrolled 16,000 youth between 7 and 21, but the period was between 1985 and 2007, and that reported the overall rate at 1.8%. So, in summary, many researchers believe that the prevalence of bipolar disorder in youth is actually similar to the current prevalence of estimates of bipolar disorder in adults. And the prevalence of bipolar disorder in youth in the United States is very similar to that of other countries as well. And just like with adults, studies indicate that the rates of bipolar spectrum disorders in youth are equally common in males and females. However, bipolar 2 and adolescent onset bipolar disorder are noted to be more prevalent in females by some studies. A large epidemiological study in the US reported 2% to actually 2.6%, with an increasing rate of bipolar disorder with older ages. So this reinforces the idea that bipolar disorder can have its onset in childhood, but prevalence is much higher during adolescence. Bipolar disorder is estimated to be the sixth leading cause of disability by the World Health Organization, so it has a considerable burden of illness. Bipolar disorder in youth is often associated with impaired family and peer relationships, poor academic performance, high rates of chronic mood symptoms, psychosis, disruptive behaviors, anxiety, substance use, medical problems such as obesity, thyroid issues, or diabetes, often related to medication management, and hospitalizations are largely increased, and the length of stay is often longer for patients with bipolar disorder as compared to those with a unipolar depression. There's a higher rate of suicide attempts and completed suicides with a bipolar disorder diagnosis as well. So, given this um, level of morbidity and mortality, early diagnosis and treatment for children with bipolar disorder is imperative. Retrospective studies in adults with bipolar disorder have reported that 10 to 20% had their onset before 10 years of age, and up to 60% had the onset before age 20. Bipolar disorder in adults is frequently preceded by a diagnosis of child disruptive behavior disorder as well as anxiety disorders. Early onset bipolar disorder is associated with a more severe course of illness and poorer outcomes, especially those children with a prepubertal onset. Youths with bipolar disorder show a continuum of bipolar disorder symptoms in severity from subsyndromal to full syndromal with frequent mood fluctuations. 70 to 100% of youths with bipolar disorder are estimated to eventually recover from the index episode. However, 80% will go on to experience another recurrence after treatment. And so, for prognosis, worse outcomes are associated with an early age of onset, a longer duration, as well as children with a low socioeconomic status, children who have mixed or rapid cycling episodes, a child who presents with psychotic symptoms, as well as children with comorbid disorders. The exposure to negative life events also can interfere with the prognosis as well as a family's psychopathology. So, family intervention, trauma informed care, and treatment of comorbid disorders are all important for the treatment plan. Some common comorbidities are disruptive behavior disorders, about 30 to 70%, as well as attention deficit hyperactivity disorder and anxiety disorders. By disruptive behavior disorders, we're including here oppositional defiant disorder as well as conduct disorder. And so, with diagnosis, we want to follow the DSM criteria. That includes a requirement for an episodic change in mood that lasts at least 4 days for hypomania and 7 days for mania. There is consensus among experts, though, that children and adolescents can fulfill the DSM criteria for both 1 and 2. However, it appears that in practice, in the US, the majority of children are often diagnosed with an unspecified bipolar disorder, often because they do not meet the time requirements for bipolar 1 or 2. There really is caution with diagnosing a child below the age of 6 with a bipolar disorder. And behavior problems do often disappear when a child's mood improves. If this is the case, then consider a bipolar disorder. Um, Otherwise, oppositional defiant disorder, conduct disorder, the symptoms are generally consistent over time. So if these are experiencing as intermittent or they're off and on for the child or the adolescent, then consider bipolar disorder. Oftentimes, though, oppositional behaviors do precede a mood disorder, so we're not going to discount the experience of the oppositional behaviors. And severe behavior problems that don't respond to treatment consider a mood disorder as well. So again, you're putting behavioral interventions, family therapy, individual therapy in place, and the child is not improving, then additional evaluation for mood disorder is imperative. Always look at the family history. And if there is a family history of bipolar disorder and the child's presenting with behavioral problems, we want to consider a diagnosis of a bipolar disorder, spectrum disorder. And behavior problems and the experience of hallucinations or delusions, you also need to consider bipolar disorder as one of the differential diagnoses, as well as schizophrenia, drug or alcohol use disorders, and medical or neurological conditions. Another area to consider with differential diagnosis is the consideration of bipolar disorder versus attention deficit hyperactivity, or are they both occurring concurrently? So, you do want to suspect bipolar disorder in a child that has attention deficit disorder if the ADHD symptoms appeared later in life, such as after the age of 10. If the ADHD symptoms appeared abruptly, and if the child stopped responding to stimulants. As well, consider bipolar disorder if the response to treatment for the ADHD symptoms seems to come and go or occurs along with mood changes. Again, one can consider the diagnosis of a bipolar disorder in a child who has attention deficit disorder if the child experiences periods of exaggerated elation, grandiosity, or depression. Decreased need for sleep is a hallmark sign for bipolar disorder in both children and adolescents, as well as adults, and inappropriate sexual or sexualized behavior. Recurrent mood swings, temper outbursts, hallucinations or delusions, and a strong family history of bipolar disorder. Especially if the child's not responding to ADHD symptoms, here's where you may suspect ADHD rather as a misdiagnosis and bipolar disorder as the main diagnosis. And we do want to use some evidence-based approaches for the assessment of bipolar disorder. And one approach is to use the FIND method. So consider the mood episodes that the child is experiencing, and in your history gathering, really hone in on identifying the frequency of those mood episodes, the intensity, the number, but especially the duration, as that is one of the key diagnostic criteria. There are some evidence-based behavioral rating scales that can be used. Some are clinician administered and others are self-report. Um, so we do have the KSADS, or the Kitty Schedule for Affective Disorders and Schizophrenia, as a psychiatric interview. It's pretty comprehensive. And some clinician-based rating scales, such as the Young Mania Rating Scale, and KSADS actually has a subscale, the Mania Rating Scale, as just one component. There are some youth, parent, or teacher self-report rating scales, and those include the General Behavior Inventory, the parent version of the Young Mania Rating Scale, and the parent version of the Mood Disorders Questionnaire. The Child Mania Rating Scale does have a parent and a teacher version as well. The Child Behavioral Checklist is a very comprehensive behavioral inventory that is useful in conducting your psychiatric interview and diagnostic evaluation. Again, you want to have mood timelines. We really need to get at those numbers and duration for this diagnosis. Psychoeducation regarding bipolar disorder and management of symptoms is so important. It's really important to instruct the child or adolescent, as well as parents, to monitor for mood and energy symptoms, as these can often be hallmark or precursor symptoms that can indicate a recurrence or a non response to medication, and or it can also be used to guide response to medication and demonstrate improvement. And so, we're going to instruct the child on assessing their mood, where they're going to give a number from positive 1 to 10, and those are the elevated moods, so going up to mild all the way up to super elevated. And then we have again, the scale going down from -1 to -10, which is slightly down, -1, and all the way down to extremely down or at the lowest point. And so each of these have definitions. We also have, again, in addition, the energy level, where again, 0 for the depressed and the energy scale. Those are just baseline. And so we can have a +1, slightly more energy, all the way up to a +10, super energetic. And we can have a -1, slightly tired, and all the way down to a -10 with no energy at all. And so instructing the individual to self-reflect and rate their mood and energy level and keep that mood diary can really help to, again, help with diagnosis. Do they meet criteria? But also help with guiding treatment and response to treatment. It's important to obtain information from multiple sources, including caregivers, teachers, or other significant adults in the young person's life, in order to accurately assess for change in functioning. And that should be measured against what their baseline or expected level of functioning for a child in that culture of that age with those intellectual capabilities would be. And so clinicians need to evaluate appropriately the intensity or restrictiveness of care when making decisions about treatment. Uh, and that would be considering outpatient treatment versus inpatient or partial response. And the presence of medical conditions that can trigger or worsen mood symptoms should also be assessed. There is not really any biological or imaging test available for the diagnosis of bipolar disorder. However, diagnostic tests that are important when considering this diagnosis do include thyroid function, whole white blood cell count, or a CBC, complete blood cell count, a vitamin B12 or iron deficiency. So these may also be used when there's an episode of any mood disorder, just to rule out any physiological cause. Now, if a child presents with a first episode of psychosis, a much more detailed organic workup is required that does include imaging such as MRI. The treatment of bipolar disorder has 3 stages. The first is the acute stage, the second is the continuation stage, and the third is the maintenance phase. The goal in the acute phase is to control or ameliorate the acute symptoms that are causing some risk in the child's life and that are affecting the child's psychosocial functioning and well being. Continuation treatment is required to consolidate the responses over time to avoid new episodes or recurrences. And so the choice of pharmacological agents as well as psychosocial interventions for each of these stages does depend on the severity of the symptoms, the phase of the illness, as well as some individual factors for the child, the subtype of bipolar disorder, the chronicity, the comorbid disorders, the child's age, and of course the family and patient preferences and expectations. Another factor is the availability of skilled psychotherapists, family or environmental interventions. What actually is available to help in that individual's community? What type of care do they have access to? And what can you do to help to enhance their access to the care that is needed? Certainly, psychoeducation is important. It's important for the patient and the family to understand what a diagnosis of bipolar disorder means. Some normalization is often helpful because it can sound kind of scary. So I often do provide a very extensive explanation of bipolar disorder, again, just being that uh, mood disorder that has two presentations rather than a unipolar depression, which is just the one pole. It's just the depressed phase, where the bipolar has two, and the other being the irritable, um, elevated mood, expansive or hyperactive phase. So, restoration of hope and reversal of demoralization that the child or parents may have because of the diagnosis is so important. As always, our patients are more than their diagnosis, so we really, want to try to help the patients to live that as well. Now, medication is often indicated, and the first line treatment are the mood stabilizers, and that does include lithium as well as anticonvulsants and antipsychotics. Lithium is still actually one of the first line medications. It is often avoided because of the requirement for monitoring. So even though it can be very helpful, the narrow therapeutic window that it has and the potential for lithium toxicity and the side effects that can occur often deter many clinicians from prescribing it. And of course, with children, many are terrified of phlebotomy, so they don't want to have their blood levels checked. So, the anticonvulsants, we do have Tegretol and Depakote also requiring that level of monitoring, maybe not as extensive as lithium, but we have oxcarbazepine or trileptal, as well as lamotrigine and topiramate, that are some second, choices. They're off label. They're not on label. So anytime moving to an off-label use of a medication, we really need to obtain informed consent for that. Now, there are those second-generation antipsychotics, such as risperidone, um, Abilify, Seroquel, olanzapine, and many of these, Latuda as well, many of these are FDA approved, and there is some monitoring required. We certainly want to monitor weight, waist circumference. You do want to get a baseline blood cell count, and you do want to assess their lipid panel and glucose and liver function over time as well. Sleep hygiene is a very important intervention for individuals with bipolar disorder. As previously mentioned, decreased sleep or even need for sleep is one of the symptoms. And so it's very easy for children, especially teenagers, to develop some very unhelpful sleep habits. So, sleep hygiene, such as encouraging them to maintain a regular sleep routine with the same bedtime and wake time every day, avoiding naps, not staying in bed awake for more than 5 or 10 minutes, but rather move to a chair, and not watching TV or reading in bed, avoiding substances that interfere with sleep, such as caffeine, cigarettes, or alcohol. Exercise later in the day can contribute to insomnia. And just really spend some time focusing on sleep hygiene. If that is a symptom that often takes time before stabilizing, and so needs to be a part of the child's treatment plan. When a child is presenting with a manic or mixed episode, um, the goal would be certainly to approach it with monotherapy, and lithium, valproate, or carbamazepine are considered helpful, and they are comparable. And manic symptoms do respond between 23 and 55%, so that's certainly not as high as we would like. But lithium is the number one approved medication for mania in children aged 12 to 17. But as we discussed earlier, it is still often underutilized today. Now, second generation antipsychotics are another choice, and the symptom response is reported to be higher with these, and they work quicker. And so there are some that are FDA approved for the treatment of mixed or manic episodes. And so risperidone can be used for the age of 10 to 17, olanzapine for the age of 13 to 17, Abilify for 10 to 17, and quetiapine for 10 to 17 as well. Monotherapy is recommended as the first step intervention. However, for kids who don't respond to monotherapy or who don't tolerate some of the medication side effects, we can try to remove some potential mood destabilizing medications, such as antidepressants, as well as optimize current treatment or switch to a different treatment, such as one of the mood stabilizers not previously tried, or can combine with other treatment options. It's ideal to use the lowest possible dose of one single agent. Of course, that is the goal. But if not able to stabilize manic, hypomanic, mixed, or depressive symptoms, then polypharmacy is utilized at times. And so some of the mood stabilizers take time. Um, so the addition of an atypical antipsychotic that is a little quicker acting is frequently used. All psychotropic medications are associated with significant adverse effects. So a careful risk-benefit analysis is needed, and it should be discussed with both the parents as well as the child when initiating medication management, and the side effects specified and reviewed with them as well. The potential um, risk for drug-drug interaction or list of prescription drugs that can interfere with psychotropic medications is long and should be checked prior to prescribing any new medication. So you always want to do your medication reconciliation. And as well, a pregnancy test does need to be performed in all females that have their menstrual cycle, and they need to be conducted both at baseline, but also whenever pregnancy is a possibility during follow-up. So talking with the adolescents about their sexual activity is important as well. And as we mentioned, there is a increased risk for sexualized behavior with the experience of mania, and so that is an area that we're monitoring. Now, uh, urine drug screens may be needed as well for individuals who may be experimenting or having issues with substance use disorder as well. And other things to monitor during medication and management include height and weight, body mass index, vital signs, and weight circumference. And that should be done at every visit. You don't want to wait too long to notice a risk for metabolic syndrome developing. And so it's important that lab tests are done, but the lab tests alone don't replace a clinical evaluation or a physical exam. And as well, it's important to assess for family history of cardiac diabetes or thyroid disease as well, just to have a good understanding of that particular patient's risk levels. And so, even though lithium is one of the first line medications recommended, we know that it has a narrow therapeutic window. The blood level needs to be between zero point 0.6 and 1.2. And elevated levels can develop toxicity, and toxicity signs include dizziness, clumsiness, unsteady gait, slurred speech, tremors, abdominal pain, vomiting, sedation, confusion, or blurred vision. And some common side effects, now this is not toxicity, but these are side effects, can include polyuria, polydipsia, tremor, and weight gain, as well as some nausea, diarrhea, hypothyroidism, cognitive dulling, sedation, and leukocytosis. So certainly we can see why this medication, while it may be very effective, why it is often avoided. Um, Fluid loss can be a problem, and so maintaining a normal fluid balance is important in individuals that are taking lithium. So we don't want too much water, that could be a problem, and we don't want dehydration either. And caffeine lowers lithium levels, so certainly monitoring your patient's caffeine intake is important. And so blood levels, again, because of that narrow therapeutic window, they really need to be obtained at first, 4 to 5 days after initiation or any dose change, and then every 3 to 6 months. Labs that need to be monitored include the BUN, creatinine, urinalysis, TSH, free T4, CBC, and electrolytes. Calcium, albumin, and weight are some additional things to consider monitoring. There is noted to be an increased risk, possible risk for suicidality with anticonvulsants. Although I did just see an alert come out on Medscape the other day where they're actually rethinking that. But we do want to monitor for neurological, cognitive, or GI side effects and increase the dose gradually. So start low and go slow. Now, there are some reasons to consider not using valproate or Depakote with females, especially females of childbearing age. It certainly is teratogenic, but it does have an increased risk for polycystic ovarian syndrome, thinning hair, and weight gain. So for adolescent girls, it's really not a good choice. Tegretol or carbamazepine, that can induce metabolism of oral contraceptives. So that's important to be aware of in your adolescent females that are taking Tegretol. It can also induce metabolism of other medicines. So there are a lot of drug-drug interactions there to be aware of. Now, oxcarbazepine or trileptal, it does not require blood monitoring and it does not induce metabolism. And so, even though it may not have the same indications as its sister drug, Tegretol, it still is often used um, because it requires less monitoring and has less side effects. Lamotrigine is not FDA approved for children and adolescents, though you will see it used. There is a lot of evidence supporting its use off label. And that's because it's effective with adults and it's usually well tolerated, has a low risk for weight gain and sedation, and is used to treat children with seizure disorders. So there is a safety proven with children. We just don't have the studies showing efficacy for bipolar disorder. And a lot of that is because we don't do a lot of research or clinical trials with children with psychotropic medication. So that is a chronic problem. Now, Topamax is another anticonvulsant that can be used, again, off label. It is certainly not on label, and it does have side effects of weight loss and cognitive dulling, so it may not be helpful in certain individuals. The second generation antipsychotics are, again, a common choice to treat bipolar disorder in children and adolescents, though there are some significant side effects with those as well. And certainly extrapyramidal symptoms, prolactinemia, sedation, orthostatic hypotension, dizziness, drowsiness, tiredness, and weight gain are some of the most significant. Now, we have to monitor and prevent the development of metabolic syndrome. So, you're going to monitor weight, glucose, and lipids, and as well measure body mass index, waist circumference, fasting glucose and lipids, as well as you're monitoring for the abnormal involuntary movements. It's important to get an EKG if the family has a history of cardiac problems, because some of the atypical antipsychotics can cause prolongation of the QRS, and so can um, have some problems there. Hypotension as well can be a problem with these medications. I think that clinicians are more aware of the potential harm that antidepressants can have for patients with bipolar disorder. However, there are times when a patient with bipolar disorder in a depressed phase may need an antidepressant. The important thing is not to treat with an antidepressant alone. An antidepressant alone can trigger a manic switch, but it can also trigger hypomania, mixed episodes, rapid cycling. And so it should be used in combination with a mood stabilizer to prevent that from happening. Oftentimes, we see a risk for increased suicidal ideation, suicide attempts, agitation with the use of antidepressants alone. Again, antidepressants may be indicated, but you really want to start low and go slow and combine it with the mood stabilizer. Medication management is just one focus for the treatment of bipolar disorder. Psychosocial treatments are very important. Supportive psychotherapy is necessary for all children and their families. And it's the psych nurse practitioner often who will provide some psychosocial interventions along with medication management. So don't forget about that side of your toolbox. You want to provide supportive psychotherapy for families with children with bipolar disorder, and specifically help them understanding what the diagnosis means and what some of the needs are, what are some preventative factors for the maintenance phase. And so specific treatment helps with psychoeducation, managing acute mania and depressive symptoms, improving their coping skills, helping them to adhere to treatment, and managing any comorbid conditions such as oppositional behavior, substance use, or anxiety. And these psychosocial treatments are imperative to prevent recurrences. And so there are a wide variety of psychotherapeutic interventions that can be utilized, such as cognitive behavioral therapy, individual therapy, family therapy, group therapy. And so it's important to identify what modality would be helpful for that individual according to their individual needs and developmental stage, and of course, with what is available in the community. There are a number of specific psychotherapy modalities or protocols that have been developed and utilized for the treatment of bipolar disorder with children and adolescents. One is the child and family focused cognitive behavioral therapy, and this was designed for 8 to 18-year-olds with bipolar disorder. And it includes intensive work with parents to support them in developing effective parenting styles that will meet their child's therapeutic needs. And it integrates the principles of reward based CBT along with interpersonal psychotherapy. And there's an emphasis on empathic validation. And so the protocol consists of 12 60-minute sessions that are delivered over 3 months. And this intervention is designed to be employed across a number of different domains. So it can be for individuals, families, at a school, at a community mental health center, and helpful to address the impact of bipolar disorder on the child's psychosocial functioning. And the key components of this program use the acronym RAINBOW, where R is for routine, so helping them to develop a routine. A is for affect regulation. I is I can do it, so that positivism. N is no negative thoughts, live in the now. B, be a good friend, a balanced lifestyle for parents. O is how can we stop this problem? And W for ways to get support. And so it's important to utilize these evidence-based approaches to to help. And if you find that there aren't any available where you're working in your clinical setting, then perhaps you can start one. And so another one that's used frequently is the family focused therapy, FFT, and that can be specific for adolescents with bipolar disorder. And the goal here is reducing symptoms through increasing awareness of how to cope with the disorder, and also how to decrease levels of familial expressed emotion. We know that that familial expressed emotion can push buttons and be triggers, especially for kids that have some affect dysregulation. So, overall, the goal is to improve family problem solving and communication skills. There are a number of different protocols that have been developed to help children and adolescents with bipolar disorder, working with them individually, as well as with engaging families. So I'll just leave you with this to just remember the importance of engaging the family when you are working with an individual with mental health challenges, because it's ultimately in the context of the family that the child needs to maintain their recovery.